So what we're going to do is we're here to expose it, let people tell their story, and let everybody in the public see the horrors of the court system in Suffolk County, New York. Hi, I'm Gary Jacobs, and welcome to Long Island Backstory, where we film at the Cablevision Studios in Hauppauge, Long Island. Please remember to like us on Facebook. My guest today is Dr. Robert Blatt, a podiatrist with over 50 years experience practicing. Who would know, because the guy doesn't look it. Actually, to this day, he still continues to work 5 days a week. Currently has an office in Little Neck, Queens. He did have one in Smithtown, which he closed recently. Dr. Blatt specializes in orthotics, so we're going to ask some questions about that. But, you know, podiatry is something I never really thought of growing up, except for maybe if I had a plantar's wart or something like that. But as we get a little bit older, you start to think about podiatry because we start to get more issues. So, Dr. Blatt, welcome to the program.
Thank you for having me, Gary. I really appreciate being here.
First question, when did podiatry begin? Is this a new field, or has it been around as long as other doctors have been around?
Well, podiatry began with Dr. Louis, who was a practicing physician some 75, maybe 85 years ago. And in his practice, he noticed that many patients were coming in complaining of foot problems. So he began to specialize in foot problems, and eventually the profession of podiatry evolved. It started off as a profession which was called chiropody, and as the years of education and the ability to do various things and the greater challenges were met, podiatry grew, and it changed its name from chiropody to podiatry. And today we're really the doctors of the feet. We really take care of everything that has to do with foot problems, from surgery, routine palliative care, limb salvage, diabetic care, orthopedics, dermatology, x-ray. So podiatry has grown quite a bit.
So what made you become a podiatrist? I mean, when you say I'm going to become a doctor, and you say, you know what, I'm going to look at smelly feet for the rest of my life. What makes you become a podiatrist?
Well, I had an uncle who was a podiatrist. Actually, he was one of the first podiatrists out here. He's just recently passed away. But he was one of the first podiatrists to practice in Suffolk County. I loved the man, and I used to visit him all the time. And he kind of was the gentleman that I really had such great respect for, that I picked up on what he was doing, and I said, you know what, I'd like to do that as well. So even in high school, people asked me, what do you want to be? I said, I want to be a podiatrist. And They said, wow, boy, you know, what do you pick podiatry? Why not dentistry or medicine? Or, you know, I said, no, I want to be a podiatrist. And as a matter of fact, I met some woman who went to school with me, and she went back to look in the school yearbook and saw that I said I want to be a podiatrist back in high school. She couldn't believe it, that I actually fulfilled my dream.
And I'm not that shocked, because I know you're passionate about podiatry. I know you personally, and you know, when you're at social gatherings, if you see somebody rubbing their feet or having a foot issue, you say, take your shoes off, let me look. So I know you're passionate about what you do. Well, so it comes as no shock to me.
I love the field of podiatry. I've been doing it, as you said, for 50 years. I'm still practicing. I love my practice. I love patients. I have a nice practice in Queens. And I get the same question all the time, you know, the same statement from many patients saying to me, you're not going to retire soon, are you? And I tell them, no, they're not going to. I'm not retiring. I'm sticking with it. And I like to hear that, because it makes me feel that, you know, I'm wanted by the people. They know that I'm older, and but they have great respect for me, and they know that I've been knowledgeable over the years with the field of podiatry.
Let me ask you, I mean, since you started 50 years ago, so when you started, it was only a 25-year or so that there was podiatry. What's changed in the last 50 years with you doing business? Because you got to keep up with it, I'm sure. A lot's changed.
Well, I think the greatest change that I've seen over the 50 years has probably been in the surgical realm. There's always changes going on in the surgery, in the education for the surgery, the approaches to surgery, The young fellas today have much greater ability in doing surgery. They're, involved, as I said before, in limb salvage, in taking care of the diabetic and trying to...
That's probably unheard of when you went to school.
Oh yeah,
reattaching a limb.
In years ago when I began, there was no such thing as limb salvage. A patient with diabetes was destined to possibly losing a digit, partial foot, up to below the knee. So that was expected. Today, they work in teams in various wound care centers and hospitals, and they're able to really perform great things for patients who have diabetes or peripheral vascular disease or any of the things that could lead to the possibility of losing a limb. So that's probably the greatest change that I've seen in podiatry.
So when should someone go to a podiatrist rather than their regular family doctor?
Well, as I said before, podiatry is the field that takes care of the foot. Any problem that a person has with the foot, from a sprained ankle to pain in the foot, to a simple palliative care like ingrown nails, warts. The greatest thing that I see in my practice is patients who come in with biomechanical foot problems, which the biggest one that I probably see and treat is people coming in with a condition called plantar fasciitis, which is also right, which is what I helped you with, my concept of how it's treated has changed. When a patient used to come into my office years ago, the first thing I would do when they would tell me this would be take out a syringe and a needle and cortisone.
Well, first tell everybody what is plantar, because I know what it is only because I had it.
Okay, plantar fasciitis is a condition which basically the bottom area of the foot, which supports the load on top, undergoes changes and is strained, overused, and is put on the stretch, and the tissue becomes tight and doesn't give with the foot. You can develop this problem based on weight problems, the surface you walk on, the shoes you wear, so many different factors. And because of that, people can develop what they get pain that usually brings them into the office is pain in the arch or pain in the bottom of the heel.
I felt like when I got out of bed, I was standing on glass, or I had something stuck in my heel. Was what.
Right. That's the tightness, the pull of that plantar fascia. You could liken it to a piece of. I always try to explain it to a patient. It's like a piece of lasagna that goes across the bottom part of your foot, and it's the supportive mechanism of your foot, and it's divided into three segments: an inner, a middle, and an outer segment. The inner segment is usually the part that's involved, and that attaches into what they call the tubercle of the heel, which is the bottom part of the heel, which is usually over here. And what ends up happening is when you first get out of bed in the morning, you're lying in bed for, let's say, 5 hours, 6 hours or more, and when you go to sleep, you lie down in bed and you just fall into a relaxed state. Everything just gives way, and you just lay there and you say, I feel good, relaxed. Well, that's not what happens with tissue. Tissue, when it goes into a relaxed state, it actually contracts. It gets tighter. So then you get up in the morning and you put your foot down on the ground, and the first few steps you take, there's a greater pull. So very often, what ends up happening is that pull translates into the pain that's around the area. There's an inflammation at that attachment, and the patient is in pain for a period of time. Once you get moving and once you start walking a while, it starts to ease up and the pain seems to get a little bit better. But nevertheless, that's what we call plantar fasciitis, or another term that people use is it's called the heel spur syndrome, because that pull over a given time can lead to the pulling of the base of the heel at that tubercle, and you end up with a shelf-like outgrowth of the bone, and that's called a heel spur. And when that develops, in most cases, it's still treated mechanically, orthopedically. As I started to say before, years ago when I began, the first thing the patient came in with that chief complaint, I would explain to them what was going on, and then I would treat it by giving him an injection of cortisone. A couple of days later, the patient would call me and say, "Doc, I don't know what you did, but you're a miracle worker. Hey, my shoulder pain went away, my knee pain went away." But a week later, 2 weeks later, they call me and say, "Doc, I need another shot." So we kind of like, or at least I did, I started to realize that this approach was just a Band-Aid method of treating the condition. And from that point on, we decided what we do is we teach them physical therapy, what they can do at home to help themselves, and there are a number of different things you can do. And also we make what's called an orthotic. An orthotic is a device that goes into a shoe. It's custom made for the patient, and that custom made orthotic, in essence, the material is determined by the weight of the patient, the age of the patient, the types of shoes that they want to wear, and the gender of the patient. So very often with that, it gives them the relief, and it gives them that long-term relief where they don't need the injection. They can do without that.
So what about the over-the-counter? I mean, the pharmacies, the drugstores are loaded with over-the-counter, orthotics that you put in with gel in them and heating and cooling and lifting.
Yeah, basically those don't work because they're empirical. A guy comes in with a size 11 shoe and he gets on a machine and he stands on it and they tell him you need a number 2 or a number 3. It's an empirical kind of an orthotic. It's not made from a cast. It's not made custom for that particular individual. And they're all basically the same kinds of materials. Many of them are made of very soft materials which are not accommodating. They're just cushions. And yeah, the patient puts it in his shoe right away and says, oh, I feel good. But over time, it doesn't really work.
Because it sort of seems different, opposite of what you would think. I would think that when I have foot pain, I want something that's soft and squishy and has all gel in it. Yet when you made the orthotic, it was basically a hard, solid piece. So why it doesn't, I would think that more padding, even when I buy shoes, more padding. Well, is padding good?
Padding is not, in that particular condition, it's not really good. What you want to do is you want to weight disperse. You want to maintain a posture of the foot. You want to place it into what's called a normal, neutral position, and you want to maintain that position as best you can. If you put something soft, it's just going to collapse under the weight of the individual. Also, the type of shoes that they're wearing, and that's a very important factor in that when you dispense an orthotic, you've got to tell the patient what kind of shoe they should really be wearing. Many of them try to put them into shoes that are non-supportive, and the orthotic just breaks down. It doesn't do anything for the patient. So yeah, in many cases you want more support, you want better control of the foot. You're not going to get it with something that's very soft and cushy.
Right. So are foot problems just a natural part of aging? I mean, does everybody eventually say, you know what, now we're getting old and listen, it happens, we're all going to get foot problems and we just deal with it?
No, I don't think so. I also believe there's a genetic component. Many of the foot problems that you see are based on genetics.
Oh, good, because I was blaming mine on my weight. Now I can blame it on my parents.
I didn't finish, but that they can be, things that you do. Putting on weight certainly isn't going to help you. But I've seen thin patients, with foot problems that, you'd expect that they wouldn't have it based on the fact that they're very thin and lean and bony. But no, they develop the same kind of problems.
So let me ask you, you mentioned shoes before. Are more expensive shoes better? If I go to the store and buy $150 sneakers, are they better than the cheap ones I'm going to get at the cheap shoe store?
No, I don't think they're any better. I think that they present themselves where they have better materials in them. They're constructed a little differently, but you certainly don't want to buy a very inexpensive shoe because in most cases they're made of synthetic materials. They're not really great shoes, but there are certain types. Like I recommend for patients to buy a sneaker that's always like a running sneaker. I don't care whether they have a foot problem or they don't have a foot problem. I find that the construction in a running sneaker is better than a walking sneaker, which is very flat. Interesting,
because there's walking, there's tennis, there's climbing.
But you get better support in a running sneaker or a cross-trainer sneaker than you would in a walking sneaker. I've seen patients come into my office wearing boat shoes, which are very flat-bottomed shoes, and they say, oh, I'm very comfortable in these. They're not the best thing for your foot, and over time they're going to cause your foot to break down. I've had personal experience where while on vacation, we were away for 3 weeks, and I lived in a pair of sandals, morning, noon, and night. Came home and said, oh my gosh, Now I know what my patients feel like when they say they're getting pain in the foot. So I made myself a pair of orthotics. I wore them for a few weeks, and the condition just disappeared. I never had to go back to them until recently, when again I did the same thing, figuring, well, I guess I'm okay. But no, it happened again, and I put them into good sneakers, good shoes, and I recommend, no, you should buy a good shoe.
What about, I'm going to ask you about a couple of the questions that are common, that come up. What about athlete's foot? Over-the-counter medicine to treat it? Why would somebody go to you? Should they go to see you?
Well, I think patients today are getting smarter, and they all have the internet. They look things up, and they actually come into my office and tell me what I should be giving them. So in most cases, yeah, you can go into a pharmacy, and many of the products that are on the shelves today are products that were, made by various companies, and now that they're out on the market, you can buy them, what do you call, over the counter, because the patent has come off of it. So you have things that at one time were prescription items. Today you can buy them commercially.
So if somebody has athlete's foot, they get itching, they go to you, or you suggest it's okay to try over the counter first?
No, I say that it's okay, but they'll very often come into my office, and I'll give them a list of things that they can buy over the counter. They should be using powders, and there's various creams that, as I said, again, came off patent and now are over the counter, and you can buy them, or you can get, depending upon their insurance, sometimes they're better off getting a prescription because the insurance actually makes it cheaper for them.
Right. What about blisters? You're all going on vacation, you go to Disney and you're walking around, and then the next day that night you get to your hotel and you got huge blisters on your feet, and now that's ruined the rest of your trip because they hurt. Well, how do you prevent them? And when you get them, do you pop them? Do you wrap them? What do you do?
Well, I just had a similar situation with my wife. She picked up a hot pot and she got burned on the finger, and you got to develop a big blister. But the point is, you never wanted the roof of blister, meaning take off the top layer of the blister. You can pop it with use of a sterile needle, or once you do that, the fluid's going to drain out. And what you want to do is put an antibiotic, a topical antibiotic on.
Like a Neosporin type?
Like Neosporin, bacitracin, triple antibiotic. And then you want to cover it with a sterile piece of gauze and compress it. Keep it compressed so that the roof of the blister doesn't fill up again. When you do that, that's quite sufficient. And eventually the area will dry out, and then basically the skin will just slough away, and you'll have a healthy undercoating.
Because if you get this on day one of vacation, it could ruin your trip.
Yeah, but you got to be, you got to prepare.
But what can you do to prevent that? I don't even understand. Why is it just from walking too much that you get?
Well, you get perspiration. The perspiration causes irritation. The area gets rubbed. Make sure that nothing is there to rub the particular spot, where you might develop a blister. One of the most common areas very often is the back of the heel. People get blisters. You see that all the time. The redness, blister forms. Make sure that your foot is not being rubbed by the back of the shoe. So lift the heel, put a heel pad in, put some cream on your foot. Many things you can try to do.
I was Googling common problems with the foot, and one of the things that came up was foot odor. That's going to turn off somebody's got foot odor. Is that just part of your natural?
No, we don't see that too often in the office. No, because people are kind of like self-aware.
But you might notice it when you take off someone's shoes and go, man, this guy's feet smell.
I don't really have a problem. Besides, I have a sinus condition, so
perfect. Maybe that's why you got
it works out well for me. But you very often find that the foot odor comes from perspiration. That's the real main cause. People have excessive perspiration. So what you have to do is you have to treat that excessive perspiration. And there are various products that you can use. If they fail, there are things that we can mix and make and give you a prescription for.
So there's no fungal problem that's causing the
No, it doesn't necessarily have to go along with fungus. It just has to do with perspiration.
Okay. What about gout? I know I'm starting to, have a lot of my friends, well, not a lot, but I've had a few friends that have got gout, and they showed up, at a trade show or work, and they say, don't go near me. If you just touch my foot, I'm going to go through the roof. It's such a painful thing. Does a podiatrist deal with gout, or is
We usually deal with
an
the
internist?
with the acute episode of gout. We see a lot of it.
Well, tell the viewers what gout is first of all.
Gout is today it's listed as a metabolic form of arthritis, where there's development of uric acid crystals that develop in a particular area. The most common area that you see is the bunion joint of the big toe. That would usually be somewhere in and around this particular area here. Now, why it predilects to that area, I don't really know, but in essence, I see a lot of it, especially today in younger people, where like in the summertime, when they have barbecues, you say to them, so how many beers did you have? Oh, I just had about 4, 5, 6. Beer is a precipitator of gout. There are other food products that can precipitate gout, but beer is a very big cause of people developing gouty problems.
Okay, Budweiser won't be sponsoring the show, so that's good. We just lost them.
You just lost them as a sponsor.
That's okay. We didn't have a sponsor anyway.
But basically, gout causes an acute inflammatory condition. The uric acid rates go up. Sometimes they don't go up. They stay on the normal side, and then after the acute episode starts to dissipate a little bit, that number will rise. But you can pretty much determine when a patient develops or comes into your office with a gouty attack, because they'll tell you, and I went to bed last night, I was perfectly fine, and about 3 o'clock in the morning I woke up and I felt like somebody put a hot torch to my foot. That's how gout comes on. It comes on precipitously. It's sudden. And when it comes on virulently. It really just gets very, very acute. I've had patients that they had to be carried into my office because they couldn't put their foot down. They couldn't put a sock on.
Yeah, that's what I've heard. So, is there anything that you can do, though, to prevent that pain, or is it strictly, they have to take a medicine?
Yeah, there are medications. And
you prescribe them?
Yeah, we prescribe them, and we usually bring the patient around to a chronic form of the condition where they're not in acute pain. They can function, they get around.
So if somebody Googles a show and they see, gout, they're going to look and say, what do I do? So you would say that their first call when they get up in pain should be to go to their podiatrist?
Well, I think podiatrists today can treat gout in the acute phase. I don't think a podiatrist should go beyond that acute phase.
Getting that person over the pain.
That person should be sent over to his internist, because it really is a matter of managing the patient with what to eat, what to do, what to wear, and getting them on medication, just like a diabetic.
Right. Now, what about, you mentioned warts at the beginning. What about Plantar's warts? What are they? How do we get them? And
Plantar's warts are caused by viruses, and it's usually a contact kind of a thing. Let's say, and you usually see it, years ago I saw a lot of kids that would come into my office. They would be away at camp, and they would change their socks in the bunk, or they would walk around barefoot. They would get it at a pool. It's a contact type of situation. Whereas many viruses that we develop today in colds usually occur because you're in an environment where, let's say you're in a movie or in an airplane, somebody coughs, sneezes, the droplets go through the air. Whereas with plantar warts, there's a contact element where a person who has had it steps, and you come along and you're susceptible to it for some reason.
So it lives on the
and it's just there,
surface.
And you step on it, and that virus is transmitted to you. I've treated warts for years, never got one, and I've touched them, barehanded, and no problem at all. So I guess there's a susceptibility to it. I've just been fortunate. I've never had any real problems with it. But that's the way usually people contact plantar.
So I've read you can put duct tape on them, and that kills the warts. Have you heard that?
There are many old wives' tales. You put duct tape on it, and it basically it cuts off the air to it. I don't really know.
What do you do for them? Because it's over the counter also.
The over-the-counter medications usually don't work, and patients get very frustrated. Why? Because they're salicylic acid preparations, and what ends up happening is they're weak. So patient puts it on, nothing really happens. They put it on again and again and again and again, and eventually they just get frustrated.
So that's what you use. You just use a stronger form.
We use a strong form of salicylic acid, or we cut them out, we burn them out, we freeze them.
Sounds painful.
It's uncomfortable, mostly because you got to give the patient an injection to do it.
Right.
So giving an injection into the bottom of the foot is not usually a very pleasant thing to do.
Right.
I don't particularly like doing it, but it is a way of treating it.
So you mentioned before that walking in flat shoes it was not good. Bowed shoes. Now you say you can pick up viruses. I always thought growing up that it was good for your feet to walk barefoot. Is it good to be barefoot?
No.
When kids run around, I used to say, "Oh, take your shoes off" to my kids. It's good to run around barefoot. Feel the pressure. Is that?
Well, it depends. If you live on an area where you're on a beach, it's great to walk around barefoot.
Because it feels good, or because it's good for your feet?
It's good because you get good muscular action.
Okay.
Today, what we try to do is tell people to wear shoes that are flexible. Years ago in the shoe industry, the first thing that a parent was told, or by the doctor, was get the kid a pair of solid, hard-bottom shoes.
Right.
That philosophy has changed. We want good muscular contraction. We want good muscular activity. So what we do is we tell the parents to put them into something like a sneaker, so that the foot can bend with the shoe, and they're getting the protection of the shoe. That's really what you want to accomplish.
So barefoot's good on the beach, nowhere else.
It's good if you live on a beach or you live in a grassy area, but if you're going to be walking around on city streets, you don't want to go barefoot. You'll pick up things, you'll step on things, and you're going to develop other problems. So
I've heard now, I'm afraid to say, because you may say it's one of these old wives' tales, if you break your toe, that there's nothing you can do about it, so why bother going to a doctor? Because there's nothing
pretty
you
much
can do
correct.
about it.
Pretty much correct.
There's nothing
There's nothing you can do about a broken toe.
Okay. What about, you mentioned before, ingrown toenails?
Yeah, when a patient comes in and they've had an ingrown nail, which is the first time they've ever had it, I try to treat them as palliative as I possibly can. I don't try to become a hero and try to eliminate it for them. If that nail is very deformed, yes, we will try to talk to the patient and tell them that this is going to repeat itself. It's like a train going down a track. It goes if the track turns, the train's going to go around that curve. So in essence, basically, you're going to have a situation where you want to just treat the condition, get the patient to as much comfort as possible, make sure that there's no infection, and so on and so forth. But if it keeps repeating itself, then what you want to do is you want to try to impress upon the patient that they should correct the problem. And the way
At home or surgically?
No, we do it surgically. In the office, we can literally eliminate the possibility of developing further reoccurring ingrown nails.
Great. Well, Dr. Blatt, thank you very much for coming. I have to say, you really lucked out because the crew is sitting there giving me the wrap-up signal, and I didn't get to the most important one, which I was going to ask you, the myth about big feet, but we're not going to get to that one. So I'm Gary Jacobs, and thank you for joining us again at Long Island Backstory. Dr. Blatt, as we said, his office is in Little Neck, Queens. I'm sure you can Google him if you'd like to ask more information on him. And please go ahead to Facebook and like our page, Long Island Backstory, and we'll see you soon.